Welcome to Doctors at Work. My name's Matt Daniel, and this podcast is part of my mission to help doctors create successful and meaningful careers. Now, whenever we move to a new team, a new hospital, or a new department, we all know that it feels in a certain way. And how a department feels, that's what culture is. But what actually is culture and how can it be changed? In this episode, Simon Fleming and myself talk about culture, how it develops, and we discuss both its good and its bad aspects. Simon shares his tips for changing culture, whether that's as a senior doctor or as somebody who's early on in their career. Welcome, Simon. Tell me a little bit about yourself.
I always find these bits really embarrassing. It's like writing a Tinder bio or something. So I'm Simon Fleming. I'm an orthopedic surgeon, currently on fellowship in Australia, in Sydney, doing my subspecialty, which is hand surgery, hand and wrist surgery. I guess the reason I'm here, the reason I'm either most well known for, or the other hats I wear, whatever your euphemism is I do a great deal of work in the medical education field. I have a PhD in operative competency. So I do a lot of work in competency assessment, basically how to make training of doctors better. And I do a great deal of work locally, regionally, nationally, internationally, uh, in the culture change space. It started in orthopedics because I always feel like you should get your own house in order, and it has evolved or grown such that I kind of talk, engage, support, mentor, strategize, you name it, with people around the world trying to make healthcare culture a better, safer, less toxic place.
What is culture?
Yeah, so there's kind of like the exam answer and the real answer. So culture for me is it's a force field you walk through. It's how we do things. It's who we are. It's how you can walk into a room and just know that it's a group of radiologists, or you can see a ward round and just know that it's a surgical ward round, and that's made up by a bunch of biases and observations. But really, what it comes down to is it's this collection of assumptions, um, and it's kind of how your community, your tribe, your organization, your system has sort of learned to survive and, at least through some lens, thrive. Um, and to be honest, it gives a sense of structure, of security, of, I know how things work. I know how things are. And that's because you have these kind of general artifacts, if you like. This is what orthopedic culture is like. This is what surgical culture is like. You've got these espoused values. That's the kind of posters you see on your hospital wall. These are our trust values. This is what we believe in. And then there are the kind of actual assumptions that make up your culture. So often your assumptions will actually differ from your values. So you might say, what's the classic one that you see on the trust wall or the NHS wall or whatever. We are, one of our trust values is respect and accountability. And then the reality is that neither of those things exist. There's no culture of respect. There's hierarchy. There's undermining. There's bullying, and there's no real system of accountability. So for me, culture is this sense of who we are, what we do. It's knowing who we are and what we do, but it's not a good thing or a bad thing. It's just a thing with many dimensions that make up what it is to be part of your tribe. There's all these cliches about, culture eats strategy for breakfast, but it's true because it's made up of all these core beliefs and core values that just shape everything about you, which is why when you're a med student, when you're a nursing student, when you're a junior doctor or whatever, everyone knows the places they want to work and the places they don't want to work, who they want to work for, who they don't want to work for. And when you really pick at it, often it comes down to culture. It doesn't, and it's a real higher order thing. You know, this place makes us feel valued. This place feels safe. This place has a really good training culture, educational culture, anti-bullying culture, anti-racism culture. It's much more that, you know, even if someone says, oh, I want to work here because there's free car parking, when you push them a bit harder, you go, yeah, just the fact that they've done that makes you feel like they really respect you and value, and you're like, oh, it's a culture thing.
So it sounds like culture kind of permeates everything, and if I think my journey through the various specialties, you walk in to somewhere, and then the place has a certain feel to it. Yeah, you know, and often you've known that even before you started. You know, if I think sort of when I rotated, you knew that it had a feel and there was a certain way, and that welcomed you, and then you recognised it. I suppose it's perhaps a bit problematic because also you become it. So if we kind of think, you know, when you and I rotate into different departments, different functions, different teams, certainly if I think for me, I'm pretty sure that I've changed. You know, I've gone into a different team, into a different world, and I've changed, or I become a different person. Is that something that happens?
Yeah, so that kind of comes into the nature versus nurture thing, but also a big component of fit. I I talk openly about, for example, my behaviors when I was a medical student, many of which I'm not particularly proud of, and I don't excuse them. Um, and you can get into the conversations about peer pressure and wanting to fit in and not wanting to be othered and on the outside, and so you find yourself adopting certain facets of that culture, but also perhaps normalizing and adopting certain facets of that culture that don't really fit in with who you are. And this is where we get into, you know, conversations around things like burnout and moral injury. So, you know, when I think about some of the behaviors that I demonstrated in my younger years, the emotions I feel are shame and anger and guilt, and kind of disgust at myself, and that's moral injury. That is where you act against your core values. And so yeah, absolutely, it's really really common to modify yourself so that you fit in a little bit. It's you know, it's pretty normal. um and the flip side is, if you start to challenge that culture, if you start to swim slightly against the stream, you immediately stand out like a sore thumb, and you other yourself, and you are either seen as disruptive in a good way, or you actually become a target and the subject of scapegoating, and it can be a real problem. But that fitting in concept is pretty common wherever you are, wherever you work.
And where does culture arise from? You know, if you think, let's say that we were putting a team together for the first time, you know, it doesn't exist. Sort of, you know, you and I, sort of, and a bunch of other people, you know, we form a group to do X, Y, and Z, and you know, there will be a culture that'll develop, won't it? But how does a culture develop from the individuals that come together?
Well, part of it is recognizing that culture in and of itself can be a source of strength. And so without sounding like a gastroenterologist, you kind of need a top-down, bottom-up approach. You need that kind of grassroots leadership aspect, and you also need that leadership, capital L leadership, if you like. And you can choose your culture. You can decide what you want your culture to look like. So you need to have a, a positive, compelling vision that kind of is based on what does our future state look like, and and you need to get people to buy into that. You need to get them to understand the kind of culture you're trying to build, and that's really difficult at an organizational level in something like, for example, the NHS. And again, don't get me wrong, there are some units, there are some departments, there are some hospital NHS trusts, there are some whole regions that have got it right, but generally not so much. They again are perceived as the exception, not the rule. And one of my favorite phrases is, you know, that the NHS isn't broken, it was built this way. So part of the challenge is that certainly UK healthcare was built, designed by straight white men to further the careers of other straight white men. It didn't really imagine women, people of color, the LGBTQ community having jobs at a same level as those straight white men. It imagined them in either subservient roles or miles down the hierarchy. And so it's not surprising that if you say, "Oh, I'm gonna set up my new unit," you know, me and Matt are gonna set up our new unit, you you immediately are faced with, well, this is how you set up a unit in the NHS. This is how the job plan. This is the job plan template, for example. So a classic example is exactly that. You know, I get asked by units, we just can't hire any women. We just don't. You know what? We're really into it. We're really into equity and inclusion, but we just can't do it. And that's not our fault. And you go, well, okay, who wrote the job plan? And it'll be a group of men, probably. And you'll say, well, have you shown it to any other people? Any women, people of color, anything intersectional, women who are also people of color? And they'll go, no. And it's only when you do that that you'll see these other characteristics starting to be shown up as missing from the job plan. So, you know, a less than full-time trainee will say, well, look, this job plan really does make it read like you don't support less than full-time working. Or this job plan really does make it sound like you don't support portfolio careers or academic educational interests or whatever. And they'll go, that's not what we meant. And there's no necessary malice there. It's shaped by, you know, unconscious bias and who and what they are, and certain kind of manifestations of things like anecdote and tradition and all this sort of stuff. And so it's really easy to say, like, oh, if I was in charge, you know, it's that whole thing of like, what would you do if you were president for the day? But actually, because culture is so ingrained in everything we do, and it's the culture as it stands is so much a foundation of everything we do and everything we are. It's actually very hard not just to change culture, but to create something new and better. So one of my favorite phrases is fundamentally, if you're not making mistakes, or if it starts to feel easy, you're probably doing it wrong. Like the moment it starts to feel easy, you're probably going with the grain because that's what feels right. And so it's really hard to deconstruct what it is that makes us, makes healthcare, makes surgeons, makes medical education, whatever it is you're trying to change. The same, keep the good bits and get rid of all the bad bits because they are so intertwined.
It sounds to me like you know, maybe those of us that are embedded in cultures, and particularly those of us in positions of power, it sounds like we're part of the problem. In the sense that we make assumptions, and like that example, you know, we wrote a job description, and you might sort of say, yeah, you know, it would be great to have more women in our department, but those men, or you know, those of us that are in power, we're part of the problem, not maliciously or deliberately, sort of not through any malice, but because we have a way of viewing the world, and that shapes what we do and how we behave, and how we act. And it's nothing to do with sort of deliberately trying to make the world awful. It's just there's a prism through which we see the world, and that means that everything that we do is shaped by, you know, I'm mixing my metaphors now, but it's shaped by the prism. That's the wrong metaphor, but you know what I
Yeah,
mean.
no, but you're not wrong, and part of it is, and conversations like this run the risk of falling into exactly that trap. Is it's really easy to blame people. Oh, the problem is you're from this generation, or the problem is you believe this, and actually that's because certainly within healthcare we have a blame culture. We have a culture that is all about pointing the fingers. You know, most of us have sat in M&M morbidity and mortality meetings, and when that first slide comes up, the muttering is generally, who did that case?
Mhm.
Who was that? Why didn't? And it's because what you really want is you want to know who to point the finger at, and you want it to not be you, rather than having a culture that's like, yeah, you know what, that was me. I made that mistake. I screwed up. I am part of this problem, and I have learned and grown from it. And again, that it feeds into why there's such resistance to change. And it's when I counsel individuals, organizations, whatever you want to call it, uh, it's fundamentally about taking them through the grief cycle.
Uh-huh.
And it's because when you think about trying to help people, leaders, if you want to use that term, but people understand why change is needed, the big resistance to change are, number one, they don't want to lose something, especially something that they perceive to be of value to them. Now, that might be power, it might be prestige, but actually, it might be what we were talking about at the beginning. It might be that sense of security that culture gives them, that sense of, I know how things are, I know how things work, I know who I am and where I stand in this world. And so that desire not to lose something is fundamentally taking someone through a loss. And so they grieve, they get angry, there is denial, they negotiate. And you see all of this when you do culture change programs. The anger comes out, how dare you call us bullies, or how dare you generalize about surgeons or orthopedic surgeons or men or whatever. How dare you? Then you get the denial, which is generally, well, this does happen, but not here, or not me, or not us, or we're not as bad as them, is very common. Then you get the negotiating, which is where you get the really performative, rhetorical behavior changes. Look, Matt, you're absolutely right. We do need to change culture. So we should probably have some yoga on Wednesdays, and we should all have to wear this special lanyard, and that will change our culture. And then eventually, hopefully, you get to acceptance. But it is still a desire not to lose something, a fear, a real fear of losing something. That that in of itself again feeds into often a misunderstanding of what it is you're trying to change and the implications. So again, another one of my favorite quotes I wheel out regularly is when all you've known is privilege, equity feels like oppression. And you will find that lots of people go, oh, well, all of a sudden now, and I see this on my social media accounts all the time, people are like, well, now as a straight white man, I guess I shouldn't apply for any roles now that the only people getting it are, and you're like, no. What it means is that certain things aren't a given anymore just because you know someone or went to school with someone or are in the right clubs or rooms. There's actually a suggestion of inclusivity and all the rest, and misunderstanding why the change is needed. So again, often you have to have conversations about why changing culture matters.
Mhm.
And the easy answers are often not the right answers. The easy answers are because it's nice or because it's kind, and that's all absolute tosh. That the real answers are it improves patient outcomes. It improves the care we offer our patients. It improves recruitment and retention. It improves workplace well-being and mental health. It reduces burnout and depression and suicidal ideation. It makes more money for the healthcare trust. It saves the NHS billions of pounds a year. That's that's why we need to change. That's the implications. You get a lot of organizations who, and again, it kind of feeds into what I was saying. They believe, and I say believe because it's often not based in fact. They believe that the change you're talking about doesn't make sense for their organization. You know, yes, there is a problem with bullying, but it's not us, or we're not bullies. So commonly I will get departments who've been highlighted for, say, bullying or racism or sexism or whatever, and they'll say, "Oh, we're being told that we're bullies, but people don't understand. It's not bullying. It's just good training." And actually, it's these woke millennial snowflake trainees or whatever. They don't believe that the change we're talking about applies to them or that it fits in because they've got this great reputation for being harsh but fair, tough love, that sort of stuff. And then finally, you have the organizations, individuals, leaders, whoever, who just they don't really have a tolerance for change at all. And you see that often in everything they do. They just don't have a growth mindset. It's very much, this is what we do. This is what we've always done. It works. I see no need to change. And again, it comes from this place of power and privilege, and I was in one unit where uh I was not particularly popular because I highlighted certain equity and diversity challenges they were facing and cultural challenges they were facing. And one of the things I pointed out was that they didn't have any women in the department. And the head of department, the clinical director of that department, pretty much said, look, I'm all for all of this equality and diversity rubbish, but if you don't care, what was it? He said something like, you should care enough about your patients to work full time. I don't want or need part-time surgeons in my department because my patients deserve a full-time surgeon. And he had basically created a culture whereby you could really only work in that department if you were both a bloke and had a support network at home in some way. It wasn't built to do anything else. And any suggestion of that was like, well, why would you mess with it? Because of course his then pushback was, well, we don't get any complaints. All of my consultant colleagues are really happy. No one hears whinging. And so you create a system whereby not only is there no room for change or growth or learning or accountability, but actually there's not even a psychological safe space for anyone to say, do we want to try something different that might work, that might not, but it's at least worth trying.
And the slightly strange thing then is that would help men as well as women. So it's not men versus women in the example that you've used is that helps men because there are lots of men that also work part-time, and also there are lots of men that have a partner that's at home that works full-time. And as you said, that old-fashioned model that you've described, that relied on the surgeon being a man and there's a wife at home and the wife runs the house and ferries the children around, and that just isn't the world anymore for
I mean,
many.
we see that in postgraduate exams, which is you are more likely to pass postgraduate exam if you are a single white man than you are if you're not.
Yeah,
And there is a distinct demonstration of differential attainment in postgraduate assessment. So if you're basically a single white man or a white man with a partner at home, you are more likely to pass than if you are a woman, a person of color, or a woman who is a person of color. And it's because, and that includes even the electronically marked exams. And it's because we're failing people even before they get to the exam center in terms of opportunities and learning and all the rest. And this is what I talk about when I say, culture is deeper and more multifaceted than that superficial stuff, is recognizing that you do need this system of accountability and change and growth so that it's not an us and them conversation. Because again, it's really easy to make this about men and women, or make this about people of color and white people. And actually it therefore allows you to use all these narratives around, well, it's a them problem.
yeah,
It's old white men who are the problem. And therefore it allows you to excuse yourself from any responsibility, any advocacy where you are making an active choice, because it kind of is, it's a bit like it's when you talk about, say, gender-based violence, one of the most common excuses people make for that sort of sexual harassment, sexual assault, and rape is, well, it's bad apples. It's bad apples that are spoiling it for the rest of us. And again, it's that them and us conversation. And it's not. Culture is all of us. We're all responsible for the world we create and what you permit, you promote. So the fact that many of us walk past things that we know to be wrong, but we let it slide because we don't want to rock the boat. We want to fit in. We're aware that maybe sometimes we're part of the problem too. That's all the complexities of changing this stuff is that idea that it's really easy to point fingers and say, the real problem is that group. And because it's that group, it's not me. It's not my problem. It's not my headache. It's them. They're the problem. And if you get rid of them, or if you change them, everything will be fine. And of course, that's not true. I recently had a medical student tell me that an ST3, so a junior registrar, said to her, there are there are two types of women surgeons, the type that shouldn't be surgeons and the type that shouldn't be women. Now that's a junior registrar. They've heard that somewhere, right? So you can't just, and not only have they heard that somewhere, but they feel empowered and emboldened enough to say it out loud and to say it to a medical student. So they are part of the problem. And of course, when the medical student told me that this was said, it was said on a ward round. No one called it out. No one challenged it. It got a laugh. So again, it would be very easy to go, well, the real problem is the person that registrar heard say that the first time. But of course, it's not. Burning that, whoever the first person to say it was, in effigy doesn't change the fact that no one else on that ward round said anything, did anything, challenged that behavior. It's far harder work changing culture than people think, because we all have to play a part in it, and we all do it or none of us do it.
Let's kind of think, what we do about it. So what can I, or, a senior doctor like myself, what can I as an individual do? I hope you're enjoying the show. Please click subscribe so you'll be notified when new episodes become available. This podcast is part of my mission to help doctors create successful and meaningful careers. You can be part of that mission too by forwarding this show to one person who you think might benefit from listening. Thank you. Now on with the show.
I think a lot of people are scared of that question because they look at someone like me and they think you have to be on your soapbox, recording podcasts, writing articles, doing that sort of thing. And actually, I don't believe you do. I think if you're going to be an advocate or an ally or an active bystander, lots of things that begin with A, it comes down to being authentic and living your values. And by that I mean, do the reflective piece. Like, who am I? What do I believe in? What kind of world do I want to work in, live in, treat patients in, have my friends, family, colleagues exist in? And then every day you have to live those values. You have to do a lot more listening. And that's really hard for people in power with privilege to do, because we're used to being, on the podium. And actually, the first thing I tell people with clout to do is to just shut up. Just be quiet and listen to those voices that often you don't listen to. We've seen it recently with some more junior doctors and with medical students speaking up about issues. And it's because you need to listen to those people that you normally ignore or talk over. And it's about recognizing that a lot of the conversations aren't about you. Some of them are, undeniably, some of them are, but some of them aren't. You have to remove yourself from that, from the center of that conversation. It's about convincing yourself and those around you that a dimension of your culture, or many dimensions of your culture, need to change, and then get an understanding for the forces at play in your space, and then get your head around some tactics to overcome those things, to change those things. And that might be learning how to be a more active bystander, right? Learning how to challenge behaviors. It might be learning how to use the Vanderbilt cup of coffee model to have conversations around unprofessional behaviors. It might be doing some reverse mentoring and having your SHO sit you down and tell you what the world is like. But that active choice to live those values every day doesn't mean being a capital A advocate and standing on your soapbox and doing the kind of stuff I do. It means just trying to be a slightly better person every day, trying to be more inclusive, create a sense of belonging, doing a lot more listening. And you'll suddenly find that the world really does kind of change around you if you start to do that. And that doesn't demand a lot, except for you to make some different choices.
What about a trainee doctor, or somebody who's earlier in their career? They're rotating through multiple departments. Every 4 months, 6 months, a year, you go somewhere else, and you find yourself somewhere that has a culture that you see as problematic? So what can somebody early on in their career do?
I mean, the advice is still the same, really. It's just with a recognition that power and hierarchy and patriarchy exist, and it's naive to think that they don't. Um, but you can still be an advocate in that way that I described. You can still live your values. You can still say please and say thank you. You can still treat people with respect. And I don't buy into this hashtag be kind thing. The kind of kind niceness narrative can actually be pretty dangerous. People talk pretty toxic. It's a often it's a tool used to silence people. Like that isn't very kind. Um, but you can treat people with respect. You can be the kind of person you want to be in the face of other things, and you can be a bystander and for others perhaps who maybe don't have as much power and privilege as you. It's where allies and mentors and sponsors come in. So yes, there is sometimes a time and a place where even a lowly fellow or a registrar or a whoever can challenge things and call things out. But sometimes um, you have to reach out to someone with more power. You know, a medical student isn't going to tell the prof that they're being a bully. It's unlikely. But if you have an ally who is more comfortable doing that, that's where your systems of accountability, your active bystander training, your Vanderbilt cup of coffee model stuff, that's where all of that comes into play. And part of the answer to your question that is the biggest problem is at the moment, those systems are not everywhere and they're not well done and they're not well delivered. And that's why we have a problem. It's why goodness knows how many years down the line, I'm still pretty busy doing work like this and having conversations like this because those systems and those structures are not in place. It is not a psychologically, emotionally, professionally safe space for a lot of people to challenge things that are fundamentally toxic.
Tell me a bit more about active bystander and the coffee cup model.
So the cup of coffee conversation is a model of having conversations around unprofessional behaviors. It's from Vanderbilt University. Now, unprofessional is a whole phrase that you can unpick for hours because it's basically a social construct, right? But the principle is, and this was based on thousands and thousands and thousands of episodes that they analyzed, that the vast majority of people in the workplace don't really have any issues, right? You and I don't have any issues, and generally you behave in an appropriate way, and general feedback allows you to grow and change and not be a problem. But say that there is a single event. I will use myself as an example here. So say I'm in theatre and I drop something, and when the scrub nurse bends over to pick it up, I say, "While you're down there," right? Um, what they talk about is an informal cup of coffee intervention. So ideally, you want someone of a similar or slightly higher level than you in terms of power dynamics to take you to one side at a safe and appropriate time and have an informal, reflective conversation. That's why the cup of coffee. So it's not Matt, my office now. It's after the case or whatever that might be. Um, you say, Matt, can we grab a cup of coffee or can we go have a chat? And you find a safe place and sit down. And either I say, can I tell you how your comment made me feel? Or I might, if I'm working on behalf of others with less power, say, can we talk about how it made others feel? Can I feed this back to you? And those conversations take time and they're not particularly fun. I've been on the receiving end of them. And you can't help but get defensive and roll your eyes and get angry and go through that whole grief cycle. But the Vanderbilt model suggests that more than 95% of people will change their behavior forever on the basis of a single informal cup of coffee intervention. Now, say that I do it again. Say I make another disgusting comment 2 days later, 3 days later. They call that an apparent pattern. And so they talk about an awareness intervention, or what I tend to phrase as a no coffee conversation. So in other words, that's the we're going to have a chat in an office. there's an email trail. Simon, I know that someone spoke to you about this informally a couple of days ago. I've heard that it's happened again. So I really do need to sit down, have a conversation with you about the values that we're trying to live, why this isn't okay. Do you need any help in changing your behaviors? But you do need to understand it's just not on. That's not how we do things here. Now, say that pattern persists. I keep making the comments. I keep making the jokes. They then talk about a guided intervention by authority, which fundamentally is an or else conversation.
Yeah.
Simon, I know that you've had a couple of informal chats about this. I know that you've also had an awareness intervention by Mr. Daniel. I've seen the emails. You need to understand that these behaviors need to stop, and they need to stop now. These are the consequences if you don't. And then at the tip of the pyramid, if you like, is what they call a disciplinary intervention. That is calling the police, calling the GMC, getting fired, being sent on gardening leave, being reported to your program director, whatever that might be. And in their study, what they showed was it's a very rare individual who gets to the tip of that pyramid, who gets to the disciplinary intervention. Because you've got to imagine someone's gone, Simon, mate, can I just let you know that made me feel really, really awful, and it really wasn't funny, and it made everyone's skin crawl, and it's not okay, and it's not safe, and whatever. And then a couple of days later, someone slightly more senior sat me down and went, Simon, seriously, stop it. It's not okay. It's not how we do things. And then a couple of days later, the clinical director or your program director goes, stop it or else. And at every turn, you've gone, nah. So it's very uncommon to get to the tip of that pyramid. The other thing that's nice about the Vanderbilt model is that there are certain behaviors which you as a department, as a unit, as a hospital, as a specialty, as a whatever, decide are unacceptable, that mandate jumping certain steps. So if I have sexually assaulted someone, I shouldn't have a cup of coffee conversation, right? That's not where that journey begins.
Yeah.
And so the Vanderbilt cup of coffee bottle has been shown to work, and it's been adapted by lots and lots of organizations. Just so that again it fits in with their culture, but it's fundamentally about it allows for learning, it allows for growth, it allows for you to make mistakes and do something dumb or say something wrong and have an uncomfortable conversation about why that is and grow and learn and do better next time. But it also has accountability at the pointy end. It means that you don't have these people who keep getting away with these behaviors because they're eminent or they're just a good surgeon or how they are or whatever. Um, and that fits in with active bystander training, and there's a number of different models, I guess. But the most common one, I guess, is a model by someone called Hocker with a C, and it's about the many D's of active bystand being an active bystander. So number one, you can delegate. In other words, you can say, I don't feel safe challenging these behaviors. But I know who I'm going to speak to. So someone witnesses you being a bit of a knob at work, and they don't feel like they can challenge you because you're the big scary boss, but they speak to the registrar or the fellow or the other consultant or the charge nurse or whoever because they say, look, this still needs to be called out. I just don't feel like I can do it. You can delay. That is to say, just because I see you doing something that's unacceptable doesn't mean I need to go off the deep end there and then. I can go away, I can collect my thoughts, I can frame how I want to do it when I want to do it. And it might be an hour later, it might be 2 days later, but you can come back and you can say, I'd now like to talk to you about how you made me feel or how some of your colleagues were upset by this action or behavior. You can distract as an active bystander. My favorite distraction is to echo things back to them. So recently someone said, "Oh, you know what foreign doctors are like," and I said, "No, what are they like?"
Mhm.
But you can also, the common one is, "Oh, I heard raised voices. Is everything okay here?" Or it's just about breaking the tension and interrupting and changing the subject. Look, if we're going to shout at each other on the ward round, can we just remember that we still have patients to see? And it's refocusing people on the task. And then the final D is declaring there are certain behaviors, there are certain actions where for whatever reason you feel safe and right to just go, Matt, stop right now. That's not okay. That's not how we do things. That's not who we are. And so you can combine being an active bystander with having some other tools in your armamentarium, whether that's the Vanderbilt model or whatever. And it doesn't take a great deal of training or money or time to build those things into your department, unit, specialty, whatever. And it's just about normalizing them. Because we normalize everything else, right? We normalize interspecialty bashing, we normalize all that sort of stuff. So why not normalize systems of being an active bystander, advocacy, having uncomfortable conversations about not okay behaviors? Because of course, once you do that, once that becomes the norm, then it's these toxic behaviors that become the exception, not the rule. Mr. Fleming doesn't buy into the Vanderbilt model or active bystander. Why? Like, why? Why doesn't he buy into it? Why? What is he so afraid of? Why doesn't he want culture to be better, safer, more inclusive? What's that all about? Whereas at the moment, it's still not uncommon for people to be like, yeah, it's all rubbish. I don't buy it. It's all nonsense. And people kind of laugh along and high five. And actually what we need to do is just normalize some of these things that we know are good for our colleagues and our patients.
And I have to say, intuitively, that feels right, because I'd say that most of us go into the workplace and we want to do a good job and we want to be good colleagues. We're not perfect, but most of us don't set out sort of to be miserable. And I really like sort of that idea of an in the moment sort of a face-to-face conversation with an equal person that you only need to be told once and you'll never do it again. I mean, if I think from my experiences, when I've gotten things wrong, and I continue to get things wrong, sort of that's the kind of stuff that certainly for me has worked, because my jaw drops and thinks, oh my God, I can't believe that's how I'm seen, or that's the impact that I have. And then it just stops, doesn't it? And it intuitively, most of us want to be good people at work, and most of us will be mortified if we knew that we were affecting other people. So that really in the moment, coffee, low level conversation, that sounds really powerful. I'll bring us to
Yeah,
a close, Simon, if that's okay. So I wonder if I could
yeah.
ask you to summarize what would be your top tips for doctors at work when it comes to culture.
I guess two things really. Um, it's about not setting yourself on fire to keep other people warm. Recognize that it is okay to stand up for who you are and what you believe in and what is right, and doing it with others. Don't let the system isolate you. And I guess for everyone, if we're going for like a general bit of advice, it's this Maya Angelou quote that I absolutely love, which is do the best you can until you know better, but once you know better, do better. It's that idea that no one's expecting you to be perfect. No one's expecting you to get it right every time, all the time. It's not possible. But it is not unreasonable to ask all of us to listen a bit more, to treat people with a bit more respect, to be a bit more inclusive, and we will just see the world change underneath our feet.
Thank you very much, Simon.